Hello and welcome in today's nursing webinar session. Myself Shanti, and we are going to talk about the first of its a rare kind of radiation technique in our facility, the very novel technique in the treatment of the cancer prevention. So let us welcome Dr. Deleep. I can't see sir. Sir has logged in.
Okay.
Sir, are you there, sir? Yes.
Yes,
So, yes, sir. So let us welcome Dr. Deleep Kumar Garu, who is our senior consultant radiology oncologist and the clinical director and from Yashoda Hitec. And let me also welcome Mr. Ramakrishna, who is our nurse manager from Hitec City, Yashoda Hospital. So we are going to talk about the radiation therapy indication in its types. So as we would like to first understand from you, sir, that what role does the radiation therapies? Yes. So we are going to understand from you what role this this radiation therapies are in the treatment of cancer in the new arena of advancement technology. Yes, sir. We would want to understand from you. Can you please unmute yourself, sir?
Yeah, I can hear you.
So can I repeat the question, sir?
I'm sorry?
Can I repeat the question?
So your voice is echoing.
Okay, am I okay now?
Yes, yes.
Yes, so I was trying to understand, we would like to try to understand here, since we have this radiation new technology in place, so what kind of preventive aspects we are going to measure in this new arena of radiation therapy? Is anybody there to help, sir? I guess there is a problem. Sir, have you unmute yourself? Yes. Am I audible, sir?
Yes, ma'am, you're audible. Give a second.
So I have too much echo, so I'm not able to hear.
Not able to hear, sir?
It's resounding actually.
So, Pawan,
let Ramakrishna finish the presentation and then we'll have a question and answer. Is that okay?
That will take a lot of time. Sir, otherwise now you're able to hear me now?
Yeah, but you have to talk very slow because it's too much echoing.
Sir, are you connected on your phone also beside? Sir, both are connected, laptop and phone. Please disconnect one.
So my voice is also too much echo for you, or it is clear?
No,
it's okay. It is okay with
us. Okay, sir.
But your voice is like too much echoing actually.
So
you're connected on multiple devices.
Multiple.
Yes, you're connected on your mobile also. I can see both actually.
I'm only on the laptop.
Okay, done.
So, sir, what is about this new radiation therapy technique in the prevention aspects of cancer? If I'm okay with my audibility now? No? Okay.
Please type. I'll write.
No. What do we do, or we should go with the slide or what?
I think a room is too much sounding, so there's
So, sir, maybe we'll just go with the slide, and in between, we would interrupt for you to just give your valuable opinion. Okay, Rama, you can read the slide.
Is it audible, ma'am?
Yes. Go.
Yeah, good afternoon. Myself, Ramakrishna. Let us talk about what is the radiation therapy.
Just a minute. Come friend, a little bit. Yes. Loud.
Yeah, radiation is a high energy radiation used to target and destroy cancer cells. It is commonly used in the treatment of various type of cancers. Example, head and neck, breast cancer, etc.
Just a minute, sir. Can you hear Ramakrishna's voice?
Yeah, I can hear, but it's echo, but that's okay. When they're speaking slow, it's good. So
Okay. So, sir, as you're able to see the slide, so is it right? Is it the statement goes with the right thing that these technologies are used for head and neck and breast cancer? I think you'll go with the statement.
correct. So the radiation therapy for any cancer patient in his journey of cancer therapy, at least 60 to 70% of the patients would require radiation therapy in some form, either as a curative or a adjuvant or the palliative. So I think Ramakrishna is going to cover subsequently. Okay. So the advancements in the radiation would help us mainly to decrease the side effects, improve the quality of life, and then we're able to target tumor much better. So probably we're improving the overall control and then the survival of the patient.
Yes, sir.
Newer technologies will help in.
So also, yes, Rama.
Let us discuss about the goals of radiation therapy. The radiation therapy main goal is that the primary goal is to damage the DNA within cancer cells and preventing them from multiplying and spreading.
So, sir, again, your valuable opinion on the same, as these are the, I think, the two main goals of radiation therapy and techniques which we are using. Yes.
Correct. So the cancer cell has a deficient DNA. The normal cell has a normal DNA. So when we give radiation, because the ability to repair is not there in cancer cell, the DNA is damaged either by something called single strand break or double strand break. So in that case, the cell will die and it will not be able to repair. But the normal cell will be able to repair, but we have to give our next fraction of radiation at least 6 hours apart. If you try to give radiation before 6 hours, okay, between one fraction to another fraction, if the duration is less than 6 hours, you'll be able to damage the normal cell also. That's the reason radiation is usually done one fraction per day over 5 days a week. Okay. There are some situations where we give radiation morning and evening, but minimum of 6 hours has to be maintained. Okay.
That should be maintained.
Common radiation, what we give is called the X-rays, mega voltage X-rays. Most common is single-stranded break. But when someone is undergoing proton therapy, there the double-strand break happens. So mainly the DNA is damaged and DNA doesn't have the required enzymes to repair. So therefore, this cancer cell will die. That is how the radiation death happens in the cell.
Yes.
Let us discuss about types of radiation therapy. There are two types: external beam radiation therapy and internal. External beam radiation therapy, a mission direct beams of radiation at the tumor from outside the body. Internally, the radioactive materials are placed directly into or near the tumor.
So, sir, could you please tell us about, we keep hearing about this ERBT and all, and also we would like to understand these internal radiation therapies, again, is it called a brachytherapy as well? Just few of your points on.
So previously we used to call external beam radiation as teletherapy. In the sense, radiation has started somewhere, we are guiding it to hit the tumor. Like a telephone, you talk somewhere and then you hear somewhere. So it's called teletherapy. Okay, so there is a gantry from where the radiation is emitted, and then we guide the radiation in such a way that to target the tumor using the modern planning systems and all. Okay,
Yes.
by shaping the beam and everything. So external beam radiation is when you give radiation from outside. The internal radiation is also called, as you said, brachytherapy. When you are placing it inside the body cavity, we call it as intracavitary radiation. But when you place some wires in the tumor and then give, it is called interstitial radiation. And when you are placing it directly in a lumen, like esophagus, it is called intraluminal brachytherapy. So this both will be required for better outcomes. But most commonly, the cancer cervix is where you see the combination of both to be done. Okay. Until unless you add brachytherapy to external beam radiation, you'll not be able to improve the survival of the patient, especially in cancer cervix patients, carcinoma endometrium, whenever they require it, which is very important. The only disadvantage with brachytherapy is, but now we have what we call it as afterloader, where the source is safely parked in a machine. You'll not have any radiation emitted. But previously, hot loading is what we call. Physically, the radiation oncologist used to load the sources into the patient. That was very dangerous. But now with all the advancements and everything, okay, so there is a misconception saying because the advancement is so much happening in the external beam, we'll be able to avoid in brachytherapy. But for carcinoma cervix, if you want to improve the cure, okay, for better local control rate and all those things, for lesser side effects, brachytherapy is must. So patients who have carcinoma cervix has undergo both form of radiation, only then they have the best outcomes.
Yes. So, Rama, you can just go first. Yeah.
Let us understand the initial planning of radiation therapy. Radiation therapy is a carefully planned and tailored to each individual patient and taking into account factors such as the type, location, and stage of cancer. And treatment typically involves multiple sessions over a period of several weeks.
So, sir, when we are talking about the planning and tailoring, when the client comes to you, it means you're tailoring and planning about the treatment plan, the modalities, and the duration of the certain period, right, sir?
So it is not a blanket that every patient with the head and neck cancer, cervix cancer would get some weeks of therapy. So each cancer would require certain dose of radiation, and we divide that radiation into uniform sessions over a period of time so that we have less toxicity. The patient is able to complete the therapy in the planned duration, and as well as we are able to clear the cancer cell. So for head and neck cancer patients, the most common duration is between 6.5 to 7 weeks. Okay. So, and then radiation is not delivered like a whole week, one day we cannot deliver because the normal cell will not be able to tolerate that much dose. There are special conditions where we do, we'll talk it about later. So we divide the dose uniformly. So most traditionally what we call it as gray. Gray is the unit of radiation.
Yes.
So for brain, most of the time we deliver 1.8 gray per session. And any other cancer, we try to deliver 2 gray per session. So like that, for head and neck cancer, we deliver up to 66 to 70 gray. For breast cancer, so what we have understood is previously we used to treat for a period of 5 weeks. So people understood that the tissue and everything over the breast area tolerates much slightly higher dose. So we improved the dose per fraction is what we call from 2 to 2.66.
Yes.
So that we could cut down the duration from 5 weeks to 3 weeks now. And then further, there were studies where they found out that even in 1 week also we'll be able to deliver radiation. This is where important, but who we can give for 1 week, whom we can give for 3 weeks. So this is the tailoring. It is not blanket that for every patient I can give 1 week.
Yes, yes.
Some patients would require only one week of radiation. They're especially stage 1, okay, low risk group, more than 40 years or 50 years. And then they are ER/PR positive, HER2 negative breast cancers where I can do 1 week of radiation. But someone who has aggressive features, I have to go for longer duration, so 15 sessions of radiation and all.
So, sir, when we are talking about, we are just, the very new terms which we are, hearing that it is a target therapy, precision-based, AI integrated, and the right fractionation, as you have mentioned. So, is these the modalities of the treatment of the radiation therapy? If I talk about the precision-based, is that mean that the right accuracy is that so, sir?
Correct. So with the advancements in radiation technology, so initially they were just plain X-rays. We used to treat radiation. So too much of radiation is to come on the skin. Then with the kilovoltage, move to megavoltage, where we are able to penetrate further. And then slightly the skin toxicity has become less and they're able to increase. But we did not have any imaging. Then the CT scan came. So we understood what is the tumor location, what is the shape of it, and then came the planning systems. So that CT we are able to transfer into system, and it's kind of doing a virtual surgery. Identify where the tumor is, and I have to identify if suppose I'm treating a head and neck cancer, then I have to identify where the spinal cord, what is the extent of spinal cord which will be in the radiated zone, parotid glands, okay, our lips, and everything which is very important to save. So I'm doing a virtual surgery. It is called simulation. Okay. We are simulating the patient in a treatment position and trying to generate a plan so that when the patient comes for treatment, we are delivering the therapy. So then after that, came the era of image guided radiation, where they were able to put a small CT scan onto the machine. So we have planned very well, but when we are delivering, if you are not able to match it and do it correctly, then probably there will be some errors which can happen. To rectify that, this cone beam CT came in. So what we used to do is we used to do before radiation, scan, verify with our reference imaging, everything, match it, and then deliver radiation. So that also, so now we are talking about era of precision radiotherapy. So now till now we have come up to accuracy. But we want to be very precise where we have delivered. So that's where this MR Linac comes in. The machine which is available only at our place in Yashoda Hospital, Hitec City, nowhere in India. So this what happens, before radiation, we do an MRI scan. While radiation is happening, we are targeting the tumor with an MRI scan. So because of that, we are very accurate as well as precise in delivering radiation. So our margins can be smaller. So the normal radiation, the organs getting radiation is also lesser.
Very lesser.
Patients have lesser side effects.
Yes.
Okay. The fractionation part, the traditional, I told you, it is 1.8 to 2 grains.
Yes.
But sometimes when we do something called stereotaxy, radiosurgery or stereotactic body ablative radiotherapy, there the radiation is between some 1 fraction to maximum of 8 fractions.
Yes.
Okay, sometimes we deliver 21, 24 grain, 1 fraction. It takes around 30 minutes to do radiation. So we have to be very precise there. Similarly, when we are trying to do radiation to liver, then we do in 5 sessions or 3 sessions. So when you're delivering so much of radiation, very high dose in less duration, we have to be very accurate. And then when we are delivering, we have to be very precise.
Precise, yes.
Okay, that's where the precision radiotherapy comes in.
So few advanced modalities you would like to speak, Rama. Yeah.
Let us discuss about a few advanced modalities of radiation therapy with advanced intelligence. Adaptive radiation therapy, intensity modulated radiation therapy.
Yes, sir. When we talk about this, as we were just going through, also there's this ART technique, as you said, optimal dose of radiation while sparing the healthy tissues, and IMRT. As you also said, this is this kind of modalities are only for selected diagnosis and all. So, what is the ART process, sir, and which cancer we like to use this treatment for?
So ART is one where either when so we have taken the patient for treatment, planned everything, patient comes in, we are doing it before radiation. What we will do is we will do an imaging.
Yes, sir.
You see the tumor has moved, okay, probably say by 3-4 millimeters because you're breathing very fast or something. Okay, so we try to correct that also. So you are adapting to that day where the tumor location is, and then generate a new plan and then deliver that plan. It is called plan of the day, and then radiation is done. So for suppose the patient when we started had a 5 centimeter tumor. So we deliver some 10 sessions of radiation. The tumor has shrunk by, or probably say it is now 3 centimeters. So the shape of the size of the tumor also changed. The shape also has changed. So what we will do is in adaptive radiotherapy, dynamically when the patient is inside, we do the scan and we again contour the whole thing and generate a new plan. So we are again adapting it to that day size and shape. So this is called adaptive radiotherapy. So this intensity modulated radiotherapy is by now standard across almost all cancers because we have the ability to spare normal structures and then deliver optimum radiation to the cancer cell. So intensity modulated radiotherapy is the almost basic technique of radiation used right now. This image guided radiation comes in when, suppose you say you're treating something in the pelvis, okay, which can move with respiration, something in the abdomen like liver, which will move with respiration. You know or don't know what is happening inside. That's when this image guided. So you're doing a CT scan before the radiation. As I told you, there is a imaging system which can be attached to the machine.
Yes.
Do a CT scan, which will help us to guide whether everything is matching or not, and then radiation is delivered.
Yes.
So the MR Linac has took it to the next level. Not only before radiation, we are able to track it while radiation is also happening.
Yes.
Okay. The stereotactic body radiotherapy, yes. So it depends on, especially someone has, I would say, a benign arteriovenous malformation in the brain. Okay, very small one. High risk for surgery, not able to do surgery, or he doesn't want surgery. Then we jump in and then give radiation. In one shot, we try to deliver 21 gray. So what will happen? All these abnormal blood vessels slowly start closing. So similarly, if they have lesion in the lung, liver, or one vertebral body metastasis, that's where this adaptive. So it is called stereotactic body adaptive radiotherapy, or it is called stereotactic body ablative radiotherapy.
So, sir, stereotactic body radiation therapy only applies for the lung, liver, spine, and brain, and as you said,
Anywhere.
anywhere.
Okay,
Yes.
whenever we are doing radiation in less than 1 to 5 sessions, okay, except for brain, we call it as SBRT. Whenever you are doing it in brain, it is called stereotactic radiosurgery.
Radiosurgery.
It's the terminology.
Yes. Great to understand that. Yes. So, yeah.
Let us discuss about the potential drawback. Patient may experience fatigue and skin irritation, nausea, or hair loss.
So here, as we used to see the conventional method of radiation therapy, and now we are in the very safest hand of technology. So we also get to see all this like radiation dermatitis and little, or as per the modalities of or the grade which you have chosen to be given to the patient, sir.
Yes. So one we have to remember is how advanced we go, whatever we go, there will be some side effects.
Some potential, sir.
Absolutely zero.
Yes.
And then one thing about radiation is wherever we are giving radiation, the side effects will be in and around that area. Unlike chemotherapy, you will not have side effects of the whole body because it is mixed in the saline and gas.
Yes.
The most visible thing is especially when you are treating very superficial. That's where you will see a lot of skin reactions, skin discoloration. So especially when patients undergoing radiation for head and neck, okay, and then breast cancer is where you will try to see the skin reactions. Okay. And one thing the nurses should understand is whenever they are undergoing radiation, so most of the diseases now have concurrent chemo radiation.
Yes.
Right? They get weekly chemo also. So when they come for chemo, just always judge. So if someone is undergoing radiation for head and neck, just look at their oral cavity, whether it is fine, is there any infection, and ask them whether they are using the mouthwash adequately, whatever is advised is taken care or not. Okay. Always advise whenever someone is undergoing radiation for head and neck, they should not, okay, shave, especially for men, because shaving can cause small abrasions. As radiation progresses, that abrasions can become very big. Okay, most of the time I tell them not to apply soap also, because subconsciously what we try to do is when you take bath, you try to rub very hard.
Yes.
The skin becomes very soft during radiation. When you try to rub, it may peel off.
Yes.
If it is a gradual process, the new skin comes and then it heals very well. You'll not see any discoloration or permanent marks. But once the old skin peels off, there is a time gap between the new skin and this. That's when you have small patches of, okay, like vitiligo.
Yes. Vitiligo. Yeah.
Same thing. So adequate hydration is very important. So I tell the patients very comfortably how to understand is like whenever you have something on a stove, okay, the vessel, if you try to touch with a dry hand and a wet hand, what is your reaction?
Yes.
Okay, the dry hand burns a lot than the wet.
Yes.
If hydration is good, so adequately taking at least 2 to 3 liters of all liquids. You have good hydration, your mucosa is wet, the reactions are less.
Less.
Okay, the fatigue also will be less.
Yes.
So similarly, whichever area they are undergoing radiation, gently tell them that you can take bath, but don't put soap. Okay. And then eating habits. A lot of liquids, fruits, vegetables in their diet. Okay, so that they don't go into constipation and all those things. This is very important. So whenever they get admitted, just inquire about this.
Yes.
So someone who is getting capecitabine, then we have to advise them that always don't get injury to your hands and foot. Okay, because the nerves get damaged because of the capecitabine tablet, and then you can have peripheral neuropathy, and it can become very bad.
Very bad.
Sensation and all. So simple counseling while they are with you for the chemotherapy and all those things, it will really help. So radiation per se, wherever we are giving radiation, that's where the side effects are more.
So simple check on these patients when they come for the chemotherapy, as Sir rightly explained. These checks are very must and educate the patient on the same. Yes. When to advise radiation therapy is the next point which we are going to discuss, and then we are done. Yes.
Let us understand the when to advise radiation therapy. We have a few methods like curative treatment, adjuvant therapy, neoadjuvant therapy, palliative care, and preventive measures.
So I think, sir, these modalities of treatment, as we were, very interestingly listening to your, valuable suggestion on the same. I think it is very much benefited the palliative regimen also. And when we talk about the preventive measures, it starts right from the detection until the plan of the cancer, sir.
Correct. So preventive measures, especially when you have genetic malignancies. Already parents have breast cancer, then we have to advise them, get BRCA testing done. If it is there, then so it has become very popular when actress Angelina Jolie when underwent bilateral mastectomy. Okay, so doing prophylactic oophorectomy will help in the risk reduction of the ovarian cancer. Okay, adequate checks, especially once they reach 35, screening for breast, and then encourage them to do self-breast examination much earlier.
Yes.
Pap smear is a simple test.
Yes.
Because from the viral infection to develop a cervical cancer, it will take you 8 to 10 years. Okay. So if you do a pap smear and you have that HPV DNA infection, then I'm sorry, next probably doing, if there is any suspicious lesion, leap or something can be done.
I think these all modalities extends the survival of the patient in a very productive way.
Yeah, mammography is one which is very important. So always ask when a female patient comes, the breast cancer, so you can proactively ask, do you have, how many children you have? Okay, do you have any daughters? What is their age? Then you can tell them that breast self-examination, go to YouTube and check. Always screen with the mammography once you reach 35 or 40 years. Pap smear is one which is very easy, a simple test to prevent cervical cancer.
Yes.
Okay, all those things.
So when we are talking about radiation safety precautions, I think use of lead aprons and TLD badges are very important, and minimize radiation exposure to the patient, because now safe technology is in the place already. Not only to the patient, even healthcare providers' safety is also a very great concern, and other paramedical staff also. And monitor the patient closely throughout the course of radiation therapy. I think that is a guideline which we follow, sir, if you agree.
Correct. And then one important thing I want to say is, especially someone who is working in cath lab or use of C-arm, your TLD badge should be outside the lead apron, not the outside the lead apron. It should be inside your lead apron.
Yes.
Okay, obviously put outside the lead apron, then it will read a lot of radiation. And then when you send it for testing, they'll say you got radiation, you have to be on radiation sick leave. It always should be inside your lead apron. So in spite of wearing the lead apron, if the TLD is leading, then you have to check whether lead apron is correct or not, functioning well. So they have to be scanned and checked and everything, if there is any leak in the lead apron and all those things. So someone who is working with cath lab or CM, so this is what you have to be very careful.
Yes.
And it's very important because once you get exposed to radiation, you cannot take it back. Okay, so prevention is better there.
So there are nurses who work beside the mound room and all. For them, it is okay because they only do the initial assessment part for the patient before they send to the
Yes, yes.
treatment.
Yeah, because the rooms, they are called bunkers. Even in the mishap of a nuclear accident, if you are in that bunker, probably you'll get very least radiation. So the walls are so thick, almost up to 2 meters in thickness. Okay, the radiation would never come out of that. So there's checks and balances. They have a servometer to check on all those things. So nurses always have to work outside that zone. If they are in the radiation department, but it's always better to give them a TLD.
Yes. Yeah.
Okay, and then the nuclear medicine also. That's where all the hot loading happens. All nurses or any staff in the nuclear medicine would require TLD. Especially they'll require even the ring badges also, where they have to wear on their fingers. Okay, that's where they are injecting the dose. So that's when the radiation is coming, especially the PET CT scans and all those things.
So we have come to the end of the discussion, and let us see the conclusion part. Yes, radiation involves assessing the effectiveness of treatment, managing side effects, as you have told, and diet and work. What diet, as you have said, I think a lot of adequate hydration. And I think while on this treatment session, they can also resume work if you agree.
Yes, yes. Many of them we encourage. Most of them for the first half of radiation, they would be fine. Probably in the second and third, second half of the radiation is where they get the fatigue and everything. So that's when they are disturbed. So the effectiveness, if you see, probably from 2 decades previous to now, people have there is a significant improvement in survival of the patients because of the effectiveness of the radiation, ability to target, deliver very good radiation dose to the tumor, and minimize the radiation to the normal structures, minimizing side effects, and maintaining the quality of life. So obviously, more and more patients will survive, but the thing is the prevalence incidence is also going up. So screening, detecting if they have also at the earliest stage, the cure will go up. Otherwise, we'll see a lot of deaths because last year alone, we have reported 9.3 lakh deaths in India from cancer.
That's
the
very,
second
very
highest in Asia.
highest, yes.
Second highest in Asia after China.
So yes, we have come to the end, and thank you so much. And I apologize. I think there was a little technical error, and we have ended the session. Thank you so much, sir, for your valuable time, and thank you, Ramakrishna. We end the session.
Thank you very much.
Thank
Thank
you.
you, sir.